Hi, welcome. Good afternoon and good morning to everybody. Thanks for joining us today. My name is Chris Bersani. I'm the Deputy Regional Administrator for the Intergovernmental and External Affairs Office with HRSA in Region 1. I'm also the Behavioral Health Co-Lead for HRSA's Intergovernmental and External Affairs. I want to welcome everybody and thank you for joining us today. This is one of a series of webinar sessions developed and facilitated by HRSA's IEA, Region 1, Intergovernmental and External Affairs Office in Region 1, in conjunction with the Northeast Telehealth Resource Center. Today's topic is on pediatric behavioral health and sustainable strategies. We have an excellent panel of guests today, and their bios are included in the information provided to you previously. So please feel free to dig into those bios, but I am going to have them do a brief introduction now, talking a little bit about their organization and some of the things that they do. We'll start out with Dr. Sarah Hagen. Sarah?
Thanks, Chris. Hi, everyone. I'm happy to be here. And I'm also happy that we have our program director and chief medical officer from Bradley Hospital joining as well, Dr. Horowitz. So she might be also making some comments and providing some feedback, which will be really helpful. But I am the program manager at PDPRN, which is our psychiatry access program, child psychiatry access program here in Rhode Island. And we're affiliated with Bradley Hospital, which is the nation's first psychiatric hospital exclusively for children. We're very proud of that and have all levels of care here in terms of providing behavioral health treatment for the children of Rhode Island.
Thank you, Sarah. We're going to turn it over to Miss Anita Morris. Anita?
Hi, thank you, Chris. I am Anita Morris. I'm a family nurse practitioner by training, work at Boston Medical Center in downtown Boston, and I'm the Director of Practice Transformation for Team Up for Children. Team Up is a very interesting collaboration. We at Boston Medical Center work with 7 regional community health centers and kind of collaborate in developing a model of integrated behavioral health care. Very honored to join today. And am also joined by my colleague and one of the representatives from one of our community health centers, Dot House Health, Juliana, who I know will introduce herself next. Thank you.
All right, Juliana, take it away.
Hi, I'm Juliana. I'm a clinical social worker. I have a degree in public health as well, and I work as an integrated behavioral health clinician in the pediatric primary care clinic at Dot House. I also manage the integration project for pediatrics at Dot House, which is a federally qualified community health center affiliated with Boston Medical Center, the safety net hospital in Boston.
Thank you, everybody, for joining us. We're looking forward to our discussion today. So I'm going to set up the first question just by saying a little bit about some data before COVID-19. So like from the years 2009 to 2019, sadly, 1 in 5 children from that period of time, ages 3 to 17, were identified as having an emotional, mental, developmental, or behavioral disorder. And suicidal thoughts and behaviors were also rising during that period of time, with close to 20% of children that age seriously considering suicide. Suicidal behaviors also went up during that time frame. So that was before COVID. So the question that I have for the panelists now is, could you describe the recent trends in behavioral health challenges that children and families are experiencing throughout the COVID-19 pandemic? I'm going to start out with Dr. Hagen. Sarah?
Hi, thanks. I think it'll be no surprise based on what you just shared, Chris, that we're seeing a market increase in mental health need in our children and families here in Rhode Island. And obviously, as you said, across the nation, that's happening as well. We're fortunate to have what we call Kids Link, which is a call line that connects parents to an experienced clinician who can help triage their care and also help them access resources. And we often use that as sort of a measure of the need in our state. And what we're seeing is that there's been a 30% increase in the call volume there, fielding around 10,000 calls at this time. So that's a huge change for us in terms of the need in Rhode Island. And we're also seeing that mirrored in exactly what you were saying in hospitalizations and ED visits and things as well in terms of crisis care. So a large increase.
Thanks, Sarah. Anita?
Thanks, Chris. So, Team Up is really an initiative that is focused in primary care. And so kind of as a complement to what Sarah was describing, can kind of speak to what we have seen from a primary care perspective. All of the Team Up health centers in and around the Boston area, across Team Up, we collect EMR data on screening rates and various different types of information about how kids are doing. And what we have seen through the pandemic is an increase in positive screeners for social, behavioral, developmental issues in children of all ages going up to 18, and kind of echoing what you were saying at the beginning, Chris, an increase in acuity. We maintain a dashboard on our website that kind of demonstrates the pre-COVID and then through COVID trends. On the kind of top left, you can see that blue line is pre-COVID. And then it kind of shows that over the 2020 and 2021 year, those screening rates have been higher, positivity rates have been higher, and that we're also seeing higher acuity. We took a look at suicidal ideation rates as well and saw that. And then the other thing I think that we're noticing, as we all know, social determinants of health really impact how kids are doing and how families are doing together. And we have also noticed an increase in positive screens for social determinants of health. At the bottom right, you will see an increase that we've started to observe, particularly kind of from April or May on, around particularly food insecurity that families are experiencing. And I think Juliana can speak a little bit more specifically to what that looks like in clinical care as well. But broadly, those are the trends that we've been seeing.
Thanks, Anita. Juliana, want to jump on that?
Yeah, I agree with both Anita and Sarah. Just a great increase in both referrals in need and also acuity in primary care. And I think the general trends we've been seeing are around increases in anxiety and depression and school avoidance for all age ranges. And the family needs around housing and food and employment, I think, have been impacting the kids as well as the families, and then also the ways in which families are able to engage in care if they are underhoused or underemployed.
Great, thank you. The second question I have, and Juliana, I'll just stay with you on this one, okay? What are some of the techniques and effective resources being utilized to increase identification of behavioral health issues in pediatric primary care? So the techniques and effective resources within pediatric primary care.
Yeah, as Anita mentioned, we are part of a project called Teen Up for Kids, and part of that is the integration piece around screening. We have a universal screening project. Part of Team Up has increased the Massachusetts mandate to screen at all well child visits. At Dot House, we use the survey for well child for illness in young children, the SWIC, for 0 to 5-year-olds, and then the pediatric symptom checklist for 5 through 18-year-olds. And then the providers also know to reflex to the PHQ-9 for older teens as well. So I would say the other piece around integration I'd like to highlight is increased training for providers, that even when screeners are low, they're below threshold, that providers are better able to identify concerns and loop in the behavioral health clinicians earlier on and think about sort of lower threshold needs.
Anita, anything you want to add before I turn it over to Sarah?
I would just maybe hone in on exactly what Juliana is talking about there. In the state of Massachusetts, there is a mandate to do universal screening and well child visits for social behavioral developmental issues. We have worked a lot across Team Up to really kind of formalize those workflows and make sure that they're really dependable, particularly through COVID, where we went through periods of time where kids were not necessarily able to come in to the health center for visits, really impacted the kind of traditional ways that you would expect to receive your care. But one thing that Juliana, I think, really focused in on is that we really see screening as part of a broader assessment. Again, just because we've been able to collect data that the health centers are sending in, we're able to see that actually, while many kids who have a positive screen, their PCP does say, yes, this child, would benefit from seeing Juliana or seeing a behavioral health clinician. There's also lots of kids who screen negative, who also that PCP says, hey, you know what, there is something going on with this family. There is an area where this child or this family would benefit from seeing a behavioral health clinician. So, we see it as kind of part and parcel of that broad kind of just inclusion and integration of behavioral health care into the way that primary care and kind of traditionally medical care is put together. I see Sarah nodding her head. Probably would have more to add to that too.
No, I thank you, Anita. We are doing something very similar in a different way through PDPRN and through MCPAP in Massachusetts, and other states throughout the East Coast also have these types of programs. We are, every state I think is working towards universal screening, right? And we're all trying to help incorporate that in. Part of some of the services that we help provide is that resource for practices that don't have integrated behavioral health in their offices. So when kids do screen positive or when they screen negative, but the parents and the team report some concern, just like you're saying, Anita, they're not necessarily. And the other thing that we often talk about with our providers here who are working on developing workflows for their screeners, especially because that changed because of COVID, as you were saying, is just, trying to maximize the effectiveness of the use of those. And so we're often, I reference this article a lot, thank you, Reed, in terms of just thinking about different aspects of the screening process that can maximize the effectiveness of that tool. And the other thing I often talk about with providers is that children who miss their wellness visits are much more likely to screen positive. And so it's really important to think about screeners as almost like a mental health vitals check. So just as you're taking a kid's weight and temperature and blood pressure, maybe when they come in, it would be great if we could also incorporate some mental health screeners. That might seem a little excessive, but for those kids that miss their well visits when those screeners are often provided, it can be an opportunity to catch another kid who might have a need. And then again, I agree with you, Anita, we're really definitely working on too, trying to maximize providers' confidence and knowledge around just talking about mental health issues with their patients, so that those screeners are there. And I think we both have provided screening tools in our resources. So thank you, Reed, for showing that. These are some common resources that we recommend in terms of places to get those tools. There you go, Reed's on.
Spot on, as usual, Reed. Thank you for sharing that. So, one of the things that's so important is catching things early with anybody, really, with any kind of behavioral health problem, but particularly with children. I think in some ways, once a child might have to, say, go to an emergency room for a behavioral health problem, in some ways we're already too late, and we want to make sure that we can address things quick. So, what are some of the techniques and effective resources being utilized to ensure prompt access to behavioral health services? I'm going to start out with you, Sarah, on this one. Let's talk about how we can get behavioral health services quickly to children.
Sure. I love this topic because we're all trying to frantically make that happen, especially with the workforce shortage that we're all experiencing. one thing I would say is access your psychiatry access program or child psychiatry access program resources within your state. So that's what we're here for, is to try to maximize, the patient's access to care and to support pediatricians or pediatric primary care providers who are trying to maybe initiate some mental health care treatment. So I have provided links to our program and to in our resources and to MCPAP, and also to the page on the HRSA website that lists all the different programs throughout the state, as well as, thank you, Reed, as well as maternal depression programs in terms of that, and also just thinking about the use of the NCPAP website as well. And that is the National Network of Child Psychiatry Access Programs. It's just a different version of collecting all the different programs across the country that are providing these services. And there's also additional resources on their website that the different states have provided and shared. So that's a good tool to kind of get started. The other thing that we often consider in terms of the work that we do here at Bradley and Hasbro Children's Hospital is using telehealth services to connect folks with services. So using telehealth warm handoffs, having joint sessions. We often have joint sessions across a medical provider and a BH provider in our services. And we've changed some of the workflow that we've been doing too, because telehealth has made that possible, which is awesome. So we're able to offer more group treatment, which is great in terms of seeing more patients at once. And also started moving towards more episodic care. And if anyone's interested in that, I'm happy to provide some research. You can email me or, but episodic care is really trying to see 2 patients at once. So, we'll see a patient for 6 sessions, have them take a month break and work on the skill and see a different patient during that time. So we're trying to rotate kids in and out a little bit faster to make sure we're seeing as many kids as possible. That's a common integrated care technique that we use here. I'll pass it off. I know Anita and Juliana have great ideas too.
Yeah, let's do it in that order. Anita and then Juliana. Thanks.
All right. So, again, Team Up is really focused on primary care and on integrated behavioral health care into primary care. The initiative kind of starts with a staffing model that includes behavioral health clinicians and community health workers who are integrated into the primary care environment. So they're there really to, kind of be able to work with the primary care providers, pediatricians, nurse practitioners, right there on site. I'll maybe talk a little bit about kind of what we've learned, we think works well for kids, but then Juliana can kind of talk, I think, also about the way that we've needed to, kind of change things up through the pandemic and really started to use telehealth a little bit more consistently there. But, so what we have really kind of found through integrated care, just one thing to note, I think, about Team Up is that we don't start with kind of like a plan of exactly what we think ought to happen in the primary care environment and how services ought to be delivered. Rather, through the initiative, kind of all of us collaborate, all 7 health centers and us at the BMC team, to decide what we think might work, try it out, and then kind of codify that into that Team Up model that Reed showed a little bit earlier. That really means that everything that we've tried to do in Team Up, it needs to be sustainable in an FQHC, even after the kind of time in the initiative ends. And so we've always really had a strong eye on sustainability and have found that this model is indeed sustainable. We are still working on parts of that sustainability, but certainly the behavioral health clinicians as kind of integrated partners in primary care has been core to that. We actually just had an article published in Pediatrics literally today. It was fantastic timing for today's presentation, that showed that kids who had a warm handoff from their primary care provider to a behavioral health provider and were seen on the same day actually came back for a second visit faster than kids who were kind of referred through traditional, kind of through your EMR means and followed up after. And one of the things I think we really have focused on is that regardless of how long that first encounter is, when Juliana kind of comes in and introduces herself to a new family, a new patient, there's always an opportunity to kind of have a therapeutic interaction with the family. So it doesn't necessarily need to be kind of a traditional hour-long appointment, and you can still really get started, provide some resources, provide some coping skills, and have a therapeutic interaction. Of course, with the pandemic, we needed to switch over to figuring out how to do all of that on telehealth, and I think have learned some positives and some limitations of telehealth as we've gone along the way around kind of that as a delivery mode. And I think, Juliana, you're probably much better able to kind of describe that in your clinical practice. So I'll switch over to you.
Yeah, at Dot House, we have clinicians and community health workers, we call them family partners. And we've really, for a long time, during the pandemic, everyone was working from home. We were all doing telehealth, and we've transitioned to a hybrid model. So we always have behavioral health clinicians and community health workers on site to see families and patients during their visits. And then we split our time, so we're available for that, and then also provide follow-up and some intervention and longer term sort of regular appointments. I do think that during the pandemic, because the behavioral system has been taxed at all levels, we've held on to patients a lot longer. And sort of, as we were talking about higher acuity in primary care, sort of that transition to other places has been harder. And that's been sort of a real difference during the pandemic. To think about sort of ways to increase access, we've really relied a lot on the EMR for communication between team members, between the providers and our integrated staff for referrals, but also just in between appointments. And I think really highlighting the role community health workers play in helping families access care in referrals and follow-up and addressing barriers.
Thank you guys so much. Very helpful. So Reed Plimpton, I'm going to pull you into the conversation here. Reed is our colleague from the Northeast Telehealth Resource Center. So the next question I have for the panel, okay, is here's the question. I'm going to have Reed maybe give it a little background on what's been happening in the world of telehealth in the last couple of years. The question is, how have your core integrated care workflows changed with the advent of telehealth services? So Reed, maybe just give a little background on what's been happening in the world of telehealth.
Sure. Yeah. Great conversation so far, guys, too. Hope I'm doing justice with the slides. And just to reiterate in the chat, guys, everybody's gonna be getting the slides, and there's far more than what I've showed so far. So look forward to that. I think to Captain Bersani's point, I kind of came into the telehealth world in a unique spot. I felt like I just got my feet settled when COVID happened. And so I was really used to the workflows that a lot of you guys, that Sarah and Juliana and Anita are about to talk about, but that a lot of folks on the line have probably heard, which is, health site to health site, or maybe to a school-based health center, right? And then with the COVID pandemic over the last 2+ years now, we've sort of had doctor to patient. That's the focus, right? You can have it at the house. You can have it at your school. You can have it at a secure location in a library or a community center. And so obviously there's patient considerations there, right? Digital literacy, digital equity, access to all of that. But there's also the very real the provider side of it, right? And so, I live in rural Maine. A lot of the providers we work with in our region are in rural areas where, maybe they're understanding that they can, activate more of their day if they're not driving in 5 days a week. Maybe it's only 3 days a week, and that commute time can be sort of used for other things. And, having gotten to work with you guys to firm up this process, and having gotten to work with you, before this as well, I'm really curious. I'm sure you have some neat ways to do it. But I also think that you probably have some, some very real lessons learned in terms of maybe some things that sounded like neat, integration or optimization strategies for workflows that maybe didn't work so well. And I think to me, that's the exciting part of where we're at, is everybody kind of sharing those types of things. Like, hey, here's what we really like that we tried. Here's what didn't make sense and why it didn't make sense. Because we, at least here in the Northeast, I know we do have a little bit of a nationwide audience today. So I'm definitely talking policy Northeast. When I think about it, we do have telehealth policy that will allow for, many of these access points to continue to be access points as long as it's feasible. So yeah, a little bit of a ramble there, but that's the framing that I'd love to hear you guys' thoughts on. And Anita, I'll pick you to start with.
Thank you, Reed. Yeah, I would say that, you know, kind of across the board when the pandemic began, it was just actually quite a remarkable feat, how quickly literally all components of the healthcare system, from, you know, community health centers, primary care, specialty care, hospital-based care, really just switched over to a telehealth platform within like kind of literally a week or 2 weeks. Right at that time, right at the beginning, what we really saw was that like all care was switched over to telehealth almost. Virtually no care was happening in person. And then over the last couple of years, most medical care that we've observed is now back in person. There's still some telehealth care, some services that are happening via telehealth, but the majority is back to in-person care. But behavioral health care has actually stabilized at about a 50-50 split, that about 50% of behavioral health visits are occurring in person and 50% of behavioral health visits still are happening by telehealth. It has obviously been an improvement in some kids being able to access care who perhaps had transportation issues or couldn't get in, or could get in, but it was a long bus ride after school. And this, you know, kind of really changed that picture. I think part of what Juliana was referencing before about more kids really being able to stay in care. And we do expect that telehealth will continue to happen and to continue to be part of the platform of service delivery. You know, I think, Reed, much to your point, we've kind of figured out what we think works well, and also figured out, you know, kind of where probably the hybrid with in-person is really important to make sure that the clinical care, the level of assessment, all really is still high quality. Juliana, do you want to maybe speak a little bit more to kind of how it works for you just in clinical practice too?
Yeah, I do think having various options has really been incredibly important. I think video plus phone plus in person has really made a big difference for families in addressing sort of that barriers to care idea. The one sort of concrete piece that's really helped for us is that we had in Zoom integrated into our EMR, so we could start visits like straight from the EMR. We could have other providers join in. We also had some other platforms available to us, like Doximity and another one called Doxy.me. So we had a lot of options, which was really nice. And then, as Reed was mentioning, in Massachusetts, we were really lucky to have Mass Medicaid, Mass Health pay for telehealth at the same rate as in-person visits, and they've, at least so far, said that that will continue, and has really helped, I think, when thinking about ways that families can access us, and we're able to be more flexible towards them. I also want to reiterate that in person, there's a lot that can get lost over the phone or by video, and we just are sort of doing the best that we can whenever we can, and in person also is really valuable when we can.
Excellent, thank you. Sarah?
Hi, thanks. I would, and a lot of what I would say is similar to what Anita and Juliana has already said in terms of some of the patterns that we're seeing, and especially in terms of behavioral health kind of staying in more of a telehealth realm and medical visits transitioning back to in-person for the majority. I think that from the lessons learned perspective, it's been interesting to see how it's affected the integrated care, the integratedness of the care that we're providing in terms of not having as much casual interaction in the conference room, or ways to grab each other and just say, hey, I just saw so-and-so and I had a question or whatever. So, you know, we've used strategies like integrating more like Zoom meetings to kind of have that informal conversation a little more formally in our integrated care clinics. I think the other thing that we're seeing is that there's a lot of pediatricians who are doing a lot more mental health follow-up. One, because there isn't as much access to care, and two, because of the integrated, like the telehealth modality, that they can see these patients more easily for follow-up. Patients are willing to do a Zoom call or a telephone call to check in. And so what we're hearing a lot from them is like, now what do I do with them? You know, they're still on the wait list, and I keep asking how they're doing, and not much has changed, and they started their medicine. And so we've kind of developed some brief interventions for them to try to initiate some basic CBT skills with, you know, kids and families. I've included those in some of the resources that we have if people are interested. We're working on creating more of those to try to help, again, practices that don't have the integrated provider in their office, you know, just for us to be a resource to them and provide some of the same services that they would get with an integrated provider there. So I think those are some of the main ways that our workflows have changed.
Sounds like you guys have adapted very well. So the final question I have for you is kind of the whole package, the continuum of care. Okay, so when we look at the full continuum of care for behavioral health issues, what are some of the successful strategies, everything from the primary care setting to hospital-based strategies, to ensure that children and families can access needed services? We know that can happen at any time during that whole continuum. Children need all of those different levels of care. So talk a little bit about successful strategies, both from the start of the primary care setting into a hospital-based strategy. So I'm going to start with you, Sarah, since you kind of see that whole perspective from where you sit.
Absolutely. Yeah, thanks, Chris. Wow. Okay. So increasing access to care across the setting, I feel like there are so many ways that we have tried, and some of them haven't been as successful as others. So I'll start with, you know, in the pediatric setting, we've definitely, as I mentioned, we're definitely providing as much support as possible to the pediatric primary care providers to initiate some mental health treatment there. To get things started, to start that access of care there, whether it be medication or some brief interventions. From the perspective of moving through the hospital system, I think we're also kind of have been adjusting in terms of the large volume of children needing higher levels of care. Telehealth has been wonderful in terms of increasing that access. By allowing more children to be seen in a group setting via telehealth, and also eliminates the issue of the burden of getting to a program, or the parents getting them to the program before or after work for those day programs. We've started providing hospital-based psychiatric consultation as well to our hospitalists who are managing a lot of the behavioral health patients that have been admitted. And, you know, that's just not their area of expertise. So offering additional supports to them and consultation to them as they're trying to manage those patients. And then I think I mentioned before, in terms of just trying to increase groups and access to care in different modalities by sharing treatment sessions and things like that, to try to make sure that kids are being seen by multiple providers at once, and getting them the maximum treatment, maximum effective treatment as efficiently as possible. I think, you know, Dr. Horace might be able to speak to this better, but we've also been working on expanding our services, our consultation services through Bradley Reach. In terms of trying to provide services in a wider way outside of Rhode Island, to increase behavioral health access to care at different hospital settings as well. Dr. Hortz, did you want to say anything about that?
Sure. Thanks. Yeah, I mean, I think that these are such challenging times, and I actually wasn't sure if you were going to talk about, you know, I know that this group isn't necessarily a pediatric hospital group, but our pediatric hospitals, unfortunately, are filled with pediatric behavioral health patients more than other sort of more physical medical conditions. And so we've also been trying to work with those teams, and have actually started to maybe even view pediatric hospitalists in the realm of primary care providers, you know, and needing to do more integrated care. And we just had a meeting with a bunch of pediatricians this weekend that said that more than 50% of their visits are behavioral health visits. So, I mean, we're really just seeing this onslaught of this exacerbation of an existing crisis. So that being said, I'll just only speak briefly, and we can talk about it again in the future, but when we pivoted to telemedicine, we at Bradley, we have a lot of partial programs, and we moved some partial programs to virtual treatment. And we are developing the ability and some collaborations to be able to provide partial care outside of the state of Rhode Island, to pair with people already providing treatment that need higher levels of care short of inpatient. You know, sort of doing our best to keep kids in the least restrictive environment, and just recognizing that there's many places around the country that just don't have all the levels of care that are needed to care for kids and keep them at home. So that's one piece of it. We're also sort of working to, you know, provide consultations and education when necessary for, you know, like water, you know, like mental health first aid and trauma-informed care and other kinds of de-escalation techniques to whoever interfaces with children anywhere that they are. So those are some of the other efforts, like less traditional, I guess, one-on-one kind of interventions to try to meet the needs of kids and families.
Dr. Horowitz, could you just tell just a little bit about what you do so people know? We didn't have a chance to really introduce you, so people.
Okay, sure. Yeah, Sarah
can
gave a
reach out
brief
to you.
introduction, so I was sort of riding on her coattails from earlier. So
Sure, of course.
I'm a child psychiatrist, and I work at Bradley Hospital. I oversee all of our child psychiatry outpatient services for our health system. Just working to get as many outpatient services of high quality available to as many kids as possible, regardless of, you know, their insurance. So that's, you know, a lifelong commitment of mine so far. And I'm also the CMO at Bradley Hospital.
And thanks so much for making a cameo today. I really appreciate it. And getting
Thank
your
you.
perspectives is so important, I think, to get all the different perspectives here from all the different disciplines and different organizations. So thanks for joining us.
Thank you.
Anita.
Thanks. So I'm also just reading through some of the questions in the chat, which I'm hoping I might be able to address just in talking about this kind of idea of the continuity in a variety of different settings where kids and families may need to access to get services. I feel like one of the most important components of that is actually the community health worker role, or at Dot House, they go by the title of family partners. Because so often those community health workers are the individuals who can, you know, as we often kind of say, go the last mile, help that family kind of move through the system to get to another spot of care. And one example from what we've done in Team Up is around developmental behavioral pediatrics, so DBP clinics at the hospital, you know, really the spot where kids go for evaluation and assessment, oftentimes around potential autism diagnosis. You know, we kind of know that it's a very scarce resource, and also that it's really important for kids to be able to access those resources or access testing in order to confirm a diagnosis, in order for services to be able to start as early as possible for that child. And, you know, through the pandemic, we went to our colleagues at in this department at BMC went to a kind of fast track telehealth approach in order to be able to get kids to be seen in a telehealth modality. And the community health workers and family partners at the health centers really provided the glue to make sure that that system worked, and health education to families at the time of referral, letting families know what to expect, why that referral was being placed, kind of address any type of cultural considerations that that would really help that family kind of decide for themselves what, within their own values and goals for their family, what was the right path of care for their child. And then would make sure that all that information got over to DBP and back. And when we started this program and really worked on developing that role, that community health worker role in that process, we saw a pretty significant decline in no-show rates for those services, and we're able to really make sure that those scarce appointments were utilized as kind of to the most optimum way that they could be. And in the chat, I've also seen questions about that role, that community health center, community health worker role more broadly. One thing that we've also noticed, there was a question about re-engaging families who perhaps kind of were just not in touch, maybe needed to relocate and were relocating out of the school system as well during the pandemic. And just anecdotally, another thing that we've observed is actually kind of community health workers or even others in the health center who may be doing COVID related work, maybe doing an immunization clinic or, kind of contact tracing where that is occurring, also starting to do just outreach activities around kids who perhaps have been lost to care. So, who are the kids, I think, Sarah, to your point before, who maybe have not been in for care recently, who we know actually may even have a higher rate of positivity on those screens. I think the logical next question is, how does the whole healthcare system really codify that function, codify that role within healthcare delivery, and ensure that it is sustainable long-term? And I would say I do not have a secret sauce answer to that. It's something that Team Up has worked on throughout our initiative. We are fortunate in Massachusetts that there has definitely been kind of sequential moves, and move more recently underfoot now too, to really transition to an alternative payment methodology for Medicaid for Mass Health. And with that, we're really seeing, kind of that flexibility open up around the definition of who's on the care team and what are all the functions that need to happen within the delivery of care to make sure that everything across that whole system works. So, a work in progress, but we're very hopeful that there's some improvements in that area that will really, kind of codify the importance of that connection role that community health workers play.
Thanks, Anita. And thanks for rolling in some of the questions and concerns from some of our participants today. Appreciate that. Juliana, would you like to add to that?
Yeah, and thinking about that question around sort of what's worked best for community health workers, we've really prioritized language and cultural congruence in the hiring of our family partners, and then also in framing the community health role at Dot House as a family partner role, thinking about hiring folks who have personal or family experience has been really crucial to helping engage families, work with families to get connected to the services that are most needed. I think in particular, thinking about those developmental behavioral services, but just sort of across the board. I also want to take a moment just to mention the school system. I think that's been a really important piece in sort of primary care, and also identification and connection to more emergency and higher need services, and being able to work with schools. Actually, I think telehealth has helped with that because we can attend meetings more easily and sort of coordinate a little bit better. I think we've really relied on that a lot at Dot House.
Yeah, thanks for mentioning that. I want to put a plug in for, a lot of our HRSA grantees, our federally qualified health centers, have school-based health centers, and it's really important, I think, to make sure that we realize the importance of meeting kids' needs in the school system and having good providers within the school systems themselves, within the schools, so that kids can be screened and provided assistance, at the school level. So definitely don't want to end on a low note, but I think what we want to start to think about is what some of the pressure points still are, some of the challenges, okay? I mean, we've all heard personal stories, and certainly in your professional dealings day in and day out. You know, people will tell you stories about getting care for children, adequate behavioral health services along the full spectrum. So you all sit in pretty unique areas in terms of how you see things. So one of the things I want to talk about is some of the gaps that you're seeing, the major gaps that you're seeing. And when you talk about that, maybe talk about some things that you see that might be promising in the area of maybe trying to fill in those gaps, or some things that, you know, might be helpful. You know, we're talking to a lot of people here, including the federal government, and we want to hear what can be done to try to close those gaps. So Sarah, I'll start out with you again on this one, and just tell us some pressure points that you're seeing and things that you think might be able to help address some of those gaps. And feel free to jump in, Dr. Horowitz, if you'd like to as well.
Yes, please. I'm also was kind of looking at the chat, and something I'm going to bring up, I think, kind of speaks to this a little bit too. So one of the, I think, gaps or pressure points we're seeing in Rhode Island, at least, is around early childhood treatment and care. So, you know, just making sure that those young kids are getting the appropriate access to the services they need in order for them to, you know, for lack of a better way of saying it, catch up developmentally, right? Or kind of, you know, get on track. And so I think that's something that we're seeing a lot of concern about in terms of how the telehealth modality has changed the services that are being provided there, and making sure that the coordination is happening for their care and service, for their treatment. And then we're also seeing, obviously, just, you know, in general, we're seeing that the demand is, you know, so high that it's hard to meet in terms of behavioral health care. And so trying to be creative about different strategies that can increase the access of care without, you know, compromising, you know, the quality of it. And at the same time, you know, making sure that we're continuing to instill hope and build resiliency in kids and things like that too. So I think we've touched on all of the different areas where this could be addressed in terms of, you know, supporting schools and making sure the connection with schools are there, and supporting pediatric primary care providers, who are often, you know, the first person families go to when they have concerns about their child, or a teenager will go to when they have concerns. Just trying to like provide any kind of creative services and coordination around that are definitely things we're trying to address. And then, you know, not to just keep talking about our program, but I love our program. So those psychiatry access resource programs are wonderful in the sense that there aren't enough child psychiatrists out there to address the needs right now. And so, you know, having access to someone who can help consult and help guide treatment for kids in a different setting can be really helpful and a really important tool. Dr. Horowitz, I'm seeing you there too, so please jump.
Well, I figured you were going to bring it up, but I did want to put in the plug for the pediatric mental health care access programs, because I think access is always going to be a problem. It was a problem pre-pandemic. It's going to be a problem. There are not enough child psychiatrists to treat all of the, probably over 20% of the population that has a mental health condition. So I think that this is going to be a chronic situation. So the more we can sort of take that resource and you know, provide support to the professionals that are seeing the kids early on, and that not just pediatricians. I think schools, you know, people are talking about that. I think we need to be thinking about early intervention and the kids even preschool as well.
I'm going to have Anita and Juliana jump in here, but just I'm looking at some of the comments on the screen here, and I just want to say, first of all, that workforce is clearly an issue. And in fact, when we were planning for this panel session, we realized how important of a topic this is and what a big topic it is. So really, we consider this to be part of a mini series. So we are going to be drilling down even further with pediatric behavioral health and talking about things such as workforce and what might be needed in order to try to close the gap when it comes to workforce in this area, and trying to make sure that children get some of the things that they need in the behavioral health realm. So I'm going to let Anita and Juliana respond to the gap question now, and I'll take a look at some of the questions in the chat too, maybe follow up with those.
Yeah, I'm trying to do the same, kind of follow along in the chat and listen to, I think what I would say is kind of the biggest gap and perhaps the biggest opportunity right now is to really expand our definition of who's on the care team and make sure that the whole payment system follows through with that as well. What this whole system really requires in order to function is flexibility and overlap across all of these roles. So everyone is really working at the top of their scope, and everyone is able to provide, kind of flexible therapeutic supports for families and children, from the front desk staff, the receptionist, to the nursing staff, behavioral health clinicians, community health workers, primary care providers, and specialty level providers. And I think what that really means is that we need to be able to start to intervene and deliver services prior to a DSM-5 diagnosis being made, and really to be able to focus upstream on, kind of as the next step after that universal screening is being able to intervene and provide therapeutic support when there are emerging risk factors or when there are emerging symptoms, but perhaps, not at the point where a formal diagnosis has been made. And, we have really tried to advocate for that. We've been very fortunate again in Massachusetts to see the state move towards supporting and reimbursing for preventative behavioral health services, which, kind of has really been, I think, a fantastic addition to releasing some of the rigidity of the system and allowing an environment where care is easier to access, and that the reimbursement structure matches that. So kind of just from a biggest gap, I think it's really making sure that the whole system is functioning, and that the kind of, reimbursement components of the system are functioning to support delivery of services to families and kids in the least burdensome way possible. And then, I think in particular, the conversation in the chat around early childhood, I would just add, really what that means is multi-generational care, and that, in Team Up, this is also in one of the slides that we added to the end. Our version is MCPAP for Moms, which is kind of the MCPAP, that consultation psychiatry access across the whole state, but supporting pediatric providers who may now be, kind of screening for postpartum depression in a young mother, and wanting to help that young mother get to care. In order to make sure that kids thrive, it's really important to make sure that the whole family thrives, which means that being able to care for and provide linkages to services for caregivers is a core component of the whole kind of, behavioral health service delivery model for children and families together.
Thanks, Anita.
Yeah,
Juliana?
I want to sort of build on that. I think community health centers are a really great place for that intergenerational work, because all of the family members are getting care there, and we can work with the providers for the babies and the moms and the teens. And we, with Team Up support, have started a perinatal program at Dot House, working with the OB nurse midwives, a specific family partner, an integrated behavioral health clinician, a case manager who does more of that sort of concrete resources, and a program coordinator. And that has allowed us to provide care to pregnant patients through the continuum into pediatrics, and looping back to the providers for moms and caregivers as their kids grow, as well as working with the pediatricians to help identify concerns early on for the kids and the caregivers. I think that's been a really exciting new piece of work for us. One other sort of less related real pain point for us, I think, is that tension between integration and needing to hold on to cases longer because wait lists are so long. I saw Alex's comment in there. She's one of my colleagues in my cohort of health centers. And that sort of idea of bridging is really exciting, that we're able to provide the support while kids are waiting to get connected. And it makes us less available to address needs in the moment in appointments. So definitely a plug for increasing capacity at all levels.
If it's
Thanks.
okay, I just want to underline something that Anita said.
Absolutely.
Which, I think that this idea of really looking at payment models to support all of the work that everybody is doing in prevention and upfront and screening, I think that the FQHCs seem to have a pretty good model that can be sustainable. And, the pediatricians that we speak to in the community that have private practices or sort of non-FQHC settings, it can be very challenging for them to sort of take the time to address behavioral health concerns in patients, which are more time consuming and don't necessarily have the reimbursement that's commensurate with the amount of time that they need to give to those kinds of presenting problems. I think it would be great for us as a community, as a country, to sort of look at how we're valuing which types of care, and to really make it so that it's care that can be provided in a sustainable way by all the people that want to provide it.
Thanks for that. Thanks to all of you for all the input. I will say that there are some questions on the chat about special populations, including refugees, and I know that there are some community-based organizations and nonprofit organizations. I just happen to be familiar with a group in Worcester who are working with Afghan refugees in particular, in the community of Afghan refugees, and making sure that their full healthcare needs are met, usually through federally qualified health centers, but in addition, behavioral health needs of that population, which are considerable, particularly with the children who've come over. So that is maybe another area that we could address in a future webinar as well. So I appreciate that. Just want to make sure that's recognized, that there are some special populations out there that need extra attention right now. I want to thank all of you for joining us today. This has been a really wonderful conversation and on a very important topic. And as indicated before, we would like to continue with a mini series on this. So we'd love to get feedback from participants today about topics that you would like us to drill down on a little bit more. And we'd also like you to fill out the questionnaire that we have here for you that just popped up, current telehealth utilization, talking a little bit about what you guys do. We really appreciate your feedback on this. The other thing is that the panelists today can be available for consultation. So just let us know. You could use us, the Intergovernmental and External Affairs Office with HRSA Region 1 for contact, and we can provide you with additional information for some of the speakers and any specific questions you might have. I want to give a special shout out to staff member in our office, Veronica Roa, who manages most of the technology and some of the content of these webinars, and she is fantastic working behind the scenes here to do this work. I want to thank all of you again for participating, and please don't forget to do the poll before you depart today. Thanks again to all of our speakers, and we'll look forward to seeing you next time. Take care.